Welcome to Day-to-Day Health, a podcast all about machine learning in medicine, brought to you by two University College London PhD students. Me, Florence.
And me, Davy.
And made possible by the Turing-Roche partnership.
Hello, I'm Davy.
And I'm Florence.
And welcome back to Day-to-Day Health. This is our podcast where we look at multimodal data in health.
And we mentioned this last time, but multimodal data is lots of different types of data. So it'd be images, blood tests, maybe videos that are taken in the course of someone's medical journey.
So I am a PhD student in UCL's SDS department, where I focus on contested illnesses and epistemic injustice, which I could get into, but it might take a while.
And I'm a PhD student in the UCL Centre for Medical Image Computing, and my PhD is looking into how brain MRI can be used to predict how long someone with motor neuron disease will survive after diagnosis.
And we are both Turing-Roche community scholars, and this year we're producing this podcast as a sort of public understanding of science endeavour. And today, the theme that we want to tell you about is how AI is being implemented in hospitals. So today we're focusing on hospitals and AI. An acronym I've run into a fair bit in my research is AIM, or AIM, which simply stands for AI in medicine. So we're looking at AIM today. So in terms of data, obviously hospitals collect and process a huge amount of data. So from stuff like patients' personal info, like their names, date of births and addresses, to things like ECG readouts, x-rays and more complex scans. And it really shouldn't be surprising here that AI is increasingly being brought in to help with this deluge of data. One thing I discovered when I had to go to A&E recently, this was due into a run-in with an extremely sharp peeler. I won't go into it, my poor finger. Anyway, so I arrived at the hospital, gave them my date of birth, and then they told me my name, my address, my in case of emergency contact, and they could bring up every single time I'd been there before and what for. And then the system sort of invisibly in the background meant that I was triaged, seen by a nurse in order to staunch the bleeding for a little bit. And then eventually I was actually seen by a doctor to get myself patched up. And then after I left the hospital, I was texted a follow-up review, one of those like, how did we do kind of things. And just in that, you can see the amount of personal data that a hospital has and the ways that it's using it. And I wouldn't be surprised if there actually was some sort of AI system already in place there. And
imagine if someone has all of that data, what they can predict about you, like, in particular.
I mean, it's a little bit scary.
Yeah.
No, for this podcast in particular, I'm going to try not to be a negative Nelly.
Okay.
I'm going to try. I mean, I do have... I don't want to be a Luddite, but I have certain concerns around AI in hospitals here. Some of it is very helpful, which we'll get to, and some of it I put my ethics cap on and sort of frown, but we'll get there.
I very much value your ethics hat, and I feel like it's useful because I've not had the training to develop an ethics hat yet. Or I forget to.
Yeah. So for this episode, I will say we are largely looking at examples from the UK and the US, and speaking about the UK in particular, an awful lot of money has been pooled into funding AI for the NHS. So in 2021, the AI in Healthcare Award announced that it would be distributing £140 million of funding grants into various healthcare applications. In 2021 alone, £36 million was invested into AI for the NHS. So why AI? Why are we putting it in our hospitals? What on earth can it do? So one of the things is innovation in making healthcare more efficient, making it cost-effective. So replacing things that cost a lot of money, like, for example, and we'll come to this part, transcribing notes and managing sort of patient flow just to ensure that people get seen really quickly. Another thing it can be used for is re-evaluating the existing infrastructure of hospitals, particularly in the wake of the pandemic, and again, seeing if it can be made more efficient or made more beneficial to patients.
And in more of a medical leaning, AI can also try and look for patterns in medical images, help diagnose diseases quickly, reduce errors. So, for example, if someone came to the hospital thinking they got cancer, maybe an AI could flag an image, say MRI, saying, I think you do have cancer and you should be seen more quickly. Or looking away from medical imaging, what about trends in like the epidemiology of diseases? If you have all the UK's data on people who have, say, tuberculosis, maybe you can find trends. Where is it happening? I mean, we saw that with the COVID pandemic. A lot of insights were gained looking at data that was coming out of hospitals.
Another thing AI can do via sensors, it can predict which patients in a ward might deteriorate or certainly monitor patients. And AI can help quickly summarise medical papers to help doctors keep up to date with the latest advancements. Because obviously the field of medicine is continuously evolving and at quite a high rate, and doctors and nurses and healthcare practitioners are very busy people. So this might be a way to cut through the jargon and make sure they have the most up-to-date and important information. AI can help support human providers to provide faster treatment, again, sort of like flagging up who needs it the most, cutting down on waiting times, things like that.
Or maybe even help develop pharmaceuticals. I mean, there is a whole field of AI for drug discovery. We're not really covering this episode, but it is a very interesting field of how we reduce the burden on people trying to make drugs by making AI do quite a lot of it for us.
And for all of these, there's the consideration that AI can learn and actually get better at tasks over time. So potentially, the longer that it's integrated into a healthcare framework, the better it gets at its job. So, in this next section, we're going to look at the various areas in hospitals where AI can be applied to help solve common problems. So I'm going to run through some medical applications. And first of all, I think it's really interesting to note that about a third of companies creating AI for healthcare applications actually focus on diagnostics. So as mentioned above, AI can help reduce errors in cancer diagnoses. And in fact, AI is increasingly becoming important in oncology, as for example, machine learning software can examine tissue for cancerous cells with precision. Florence is going to tell us a bit more about that in a moment. And just as some examples here, we've got a study that found an AI algorithm detected skin cancer at the same level as dermatologists. And this was in 2018, so they could have been very much improved by now. And a more recent study on breast cancer diagnostics found that AI decreased the human error diagnosis rate by 85%.
Just coming back to a lot of AI companies focus their resources on diagnostics. From my personal opinion, this is not empirical evidence, so don't sue me, but I think it's quite a lot of an easier task to do diagnosis. All you need is some data and then a label on it saying this person has a disease or this person doesn't have a disease. Comparing that to other tasks like prognosis, where you're looking at how someone's disease will progress into the future, you need multiple time points of that person. So you're basically quadrupling, five-tupling. You're doubling, tripling, quadrupling your efforts of collecting that data. So it's quite a lot of a more labour-intensive, logistically intensive task to do. So I can understand why people would do diagnosis, and also, like, it's a valuable task. I'm not poo-pooing diagnostics with AI. Like, it's incredibly valuable.
Yeah, no, for sure.
But not super surprising to me, anyway.
Yeah, no, I hadn't considered how comparatively easy that is.
Yeah.
So outside of oncology, and this is what I consider to be quite a wild example, which is why I kind of wanted to bring it to the table. An AI software company had their deep learning program listening to emergency calls, like 999 calls, and its algorithm analysed what the person said, the tone of their voice, and the background noise, and could use that to detect cardiac arrest cases with 93% accuracy versus 73% for humans.
That's mad.
Yeah, but I've got to say, I am a little bit like, this is one of those occasions where I put my ethics hat on and sort of scowl a little bit because I'm just like a teensy bit skeeved out that the company was allowed to do that. Like, A, there is absolutely no way you can get participant consent before doing that. And B, it feels exploitative, like you're scraping data from like the worst moment in someone's life potentially and using that to train your algorithm. I do see that there is like practical and beneficial aspects to doing this, but as I say, I have my reservations. However, I shall save that for my ethical gripes section in a moment. I know, get hyped. So yeah, continuing with these sort of medical applications here, another thing is that AI could help with a number of routine procedures and tests. For example, in the case of endoscopies, AI can lower the possibility of human error, better characterise lesions, interpret pictures quicker, and enhance the identification of tiny lesions that human practitioners might miss or find difficult to identify. AI can also help with identifying and removing colon polyps, which are the precursor to colon cancer, not in all cases, but as a preventative measure, they will usually be removed as standard. And this thereby helps with early diagnosis and improved survival rates.
And a fun fact from me is that one of my master's coursework on the AI-enabled healthcare Masters of Research was to create an AI to identify colon polyps from colonoscopy images. Be glad I did that for you. It was months of looking at colon polyps and creating an AI to do that, and very valuable work. But I'm quite happy that I look at brains instead of colons, I'm not going to lie.
Yeah, you never have to look at another polyp.
I never have to look at a colon ever again.
Thankfully, the AI is taking over in that area a little bit. So yes, what else can AI do? AI can also monitor patients in the hospital, as I mentioned previously. So this is like via various sensors, and it can do things like provide fall detection and sense temperature changes, which can be useful in sort of determining whether a person might have an infection or a fever. And the company NVIDIA actually have an AI system called Clara Guardian that helps developers build these systems into hospitals. So that might be something that we see a lot more of in the future. And then finally, for this little section, I'm going to bring up AI-assisted robotic surgery, which I think is fascinating and very cool. So, for example, certain robot-assisted surgeries are minimally invasive. They use very small incisions, which means you heal quicker, you stay in hospital for shorter periods. And these AI-assisted robots can also use data from past operations to improve the next ones. One study suggested that an AI-assisted robotic procedure resulted in 5 times fewer complications versus a surgeon working alone. So yeah, very cool, a lot of possibilities there. However, I'm not going to tell you much more because we'll be talking about this subject more in depth in our next episode, which will focus on AI and surgery. Ooh. So yeah, watch this space.
So back to oncology. We were talking about kind of diagnosing breast cancer early because that is just it seems like a very, very good thing to do. So people know early if they've got breast cancer, they can get treatment. And hopefully the treatment is more successful than it would have been if it had been left to kind of progress more without a doctor knowing. But I cannot find the paper where I read this, which is really annoying, but it was a couple of years ago now, so I'm going to let myself off for that one. But take this with a pinch of salt, in case I'm misremembering. But there was a paper that had looked into diagnosing breast cancer early, and although it had caught more cases, qualitatively from the experience of the people who had their cases caught by the AI that wouldn't have been caught by a doctor, some of these people were in their 90s, they've been told they have breast cancer, and to be honest, it actually, for them it caused them more distress to know because it probably wouldn't have changed their outcome.
Yeah.
To know and not know. So it makes their final years just that bit more difficult. And on the other side, AI is great for this sort of thing, but quite often it can lead to quite a few false positives. So AI is great, and often it can increase the accuracy, but accuracy is only one part of the story. Sometimes with that comes an increase in false positives. And I'll talk about that later as well, but false positives is where you think someone has the disease, the AI thinks someone has the disease, but actually they don't. And that can cause a lot of distress for people who are part of that false positive chain. Like imagine you're told you've got breast cancer, you need to come in for a mammogram, which is quite a horrible procedure from what I've been told, to just find out, oh actually, sorry, the AI was wrong.
That also makes me sort of worry, and maybe this is more theoretical, but it makes me sort of concerned about well, what if you get given treatment for a thing that you don't have and that harms you? I'm just thinking radiology or chemotherapy or something like that. Obviously they will probably catch it before it gets to
hopefully it wouldn't get that far.
But
even just the beginning diagnostic stages, having a biopsy, that is not something that is without consequence. That is tricky. You've got to take time off work, find someone to look after the children. Even logistically, that can cause some issues. And there's something to be said for kind of utilitarianism for the greater good. If more people get found out to have breast cancer and they get their lives saved, and it's worth it. But all of this feels like a cautionary tale of not just relying on, we caught more cases, this is good. You need to look at everything. How many false positives did you get? How many false negatives did you get? We thought this person didn't have breast cancer, actually they do have breast cancer. It's all part of the picture.
Yeah, for sure.
Moving away from medical applications, more to like operational applications. AI and data-driven approaches can be pretty useful in improving the operations of hospitals and the patient experience. So one of these areas is triaging. I didn't know what triaging was before I started my PhD, so I'm going to explain what it is just in case other people also don't know. Triaging is where somebody is assessing how urgently a patient needs help. So you try and get a diagnosis or like the start of a diagnosis and be like, oh, we should see this person sooner than someone who's got a sore tummy and they probably just ate a lot of cheese. So I've got 2 examples where AI has been used in triaging within specifically the radiology department, which is where all the MRIs, X-rays, CT scans, kind of images will go in a hospital. So before starting my PhD, I had no idea how radiologists work. But it turns out it is a tough old job. So there's a global shortage of radiologists. And these are the people who are actually going to read the scans that we're all getting. And it takes a long, long, long time to train to be a radiologist. And on top of that, we're also all getting more scans than we ever have because it's easier to do so and cheaper to do so. So there are less radiologists.
And more scans.
And more scans.
Oh, no.
And the way radiologists work, from my limited knowledge, is they will just sit at a desk and go through hundreds and hundreds of scans in one sitting to try and just get through the backlog, to get these scans assessed as quickly as they can. And interestingly, at least in the NHS, there is a first in, first out queuing system for these scans to determine which scans get seen first. So it's completely a queue. There's no thought behind the queue. It is, this person got done on Monday, we've got to see them first. So there are 2 papers that I found that are trying to improve this queuing system, trying to scrap the first in, first out, and try and put a bit of logic to it, basically. So one of these is by David Hua and colleagues from the University of Sydney, looking at how an AI triaging system could work within a hospital ecosystem, so actually in place, to improve the efficiency and accuracy of diagnosing tuberculosis from chest x-rays. So what's especially interesting about this paper is that they had quantitative results, as you'd expect, so like how well the system is improving the turnaround time for scans, which is how long it takes for the scans to get taken and then assessed and then, finished looking at, which did improve with AI involved. They also had qualitative results. They had quotes from the radiologists who are working alongside the AI.
Oh, interesting.
Yeah, because it's important to note that all this stuff definitely is human. It's called human in the loop is the phrase. And it's saying that these systems do not work alone. There has to be someone monitoring them, working alongside them like a colleague.
You can't let the AI sort of run off on its own in case it starts. I suppose especially in case it starts, it learns one slightly wrong thing and then sort of runs off on a tear and ends up misdiagnosing everything.
Yeah, and if a human makes a mistake, usually it's a logical mistake. If an AI makes a mistake, it can be just utter nonsense. Not all AIs, but that is kind of the case. I mean, have you gone on ChatGPT and it's just gone haywire? And you're like, what are you talking about? Like, that's just not true.
I have a confession to make, and that is I have never used an AI tool. And
That's mad.
It's not due to some sort of ethical thing. It's just I'm a little scared of them. I'm not scared, that sounds silly, but I'm not like, oh, Skynet, it's going to kill us all.
Tinfoil hat.
I know. I should probably get on something like Midjourney and just sort of let some nice images, be generated, and then I'll chill out a bit. But
I use ChatGPT every single day. Not for everything, but I write an email and I'm like, let me just check how good this email is, because I'm awful at writing emails.
Oh, fair enough.
Yeah.
Sorry, took us off track there. Human in the loop. Yes.
Human in the loop. So we've got some quotes from radiologists, and there was a mix of positive and negative, and there are only a couple quotes. I imagine there was more that they'd collected. But one positive said, and I quote, AI helps reduce human error by pushing up the most important cases before we get tired. And one negative from a radiologist said, the false positives are a nuisance and more work. I have to spend extra time before deciding it's incorrect. So it's kind of 2 sides of the coin. Someone's saying it's good because if you're sitting at a desk looking at hundreds of scans, by 451, your eyes might be getting tired. You might be thinking, Yeah.
They all just blend into one another at that point.
They 100% all blend into one another at that point. They're all black and white. They're all pretty blurry. Like, you're like, sure. And no fault to the radiologist. Anyway, anyone would get tired doing that. So I can see it being helpful. And AI says, look at these ones first. These are the ones that I think are weird, but you're going to have to spend a bit more brain power on. And the negative is interesting too, because like we had just talked about, false positives, they are a nuisance. If an AI is like, this one's weird, and then someone looks at the scan and goes, no, it isn't. And it's just, I imagine there's more frustration there, even if you were going to see that scan anyway, and you'd be like, no, that's normal, that's fine.
I suppose, yeah, I don't know. This is projecting, so I apologise to radiologists everywhere. But like, I imagine if an AI told me, "Look at this is important," and I looked at it, I'd be like, "Why is this little robot? It's not a robot, but why is this little robot taking over parts of my job when I can tell you definitively that is a normal human?"
Well, like I said, it's a colleague.
Yeah,
it's a colleague, and you're like, you are making life harder for me right now. Like, why don't my boss talk to you? Get you sacked. So, yeah, I thought that was quite interesting, looking at how radiologists actually feel about these systems, and especially this one, because this was a commercial AI application. This was in-house in the hospital being used, so this is straight from the horse's mouth, so to speak. And another case of AI triaging, David Wood and colleagues from King's College London in 2021 published a paper about automated triaging of head MRI to detect abnormalities in the scans. So that's basically scans with kind of weird things going on, like stuff you wouldn't expect to be in a brain. Tumours, lesions, just some interesting stuff. So if the AI found something abnormal, this MRI would get pushed up to the top of the queue. And they found that the average time to finish analysing a scan was halved in one of the hospitals they looked at, from 28 days to 14 days. That's the turnaround time we were talking about before. And that's in a hospital in London. And in a hospital in a rural part of England, in Cheshire, that was changed from 9 days to 5 days after using the AI. And what's kind of especially interesting about this technology is how this AI could handle such different environments. I mean, it probably doesn't sound that different because they're both, in England. But a busy hospital with a large multicultural population serving lots of different residential areas in London versus a smaller hospital in a very rural area where the population would look a lot different. These two groups of people are going to be quite different, and I think they're going to have quite different problems. So an AI that can look at both of these populations and still make accurate readings is called generalizable, and this is kind of an issue of generalizability. And this is really important for AIs to strive for, because it's not super useful if your AI works really well in one particular part of London in one given year with specific conditions, but completely fails 10 miles down the road. Then there's going to be absolutely no point. You can't make an AI for every single hospital.
Yeah.
Because also populations change through time.
Yeah, no, for sure. So since we're looking at these little case studies of where our AI has been deployed in hospitals, I wanted to bring up this little case study of the Mater Misericordiae University Hospital in Dublin. I do apologise if I've said that wrong. I did my best. Latin, not my strong suit. But so in this hospital, which was the first hospital in Ireland to use AI in its radiology department, so first of all, this software was put through rigorous testing between April and August of 2023, and then was fully deployed across the radiology department in autumn last year. Since then, the software has helped assess more than 15,600 patient scans. And what it does is it just basically notifies the radiologist of suspected hemorrhages and pulmonary emboli. That's its area. And since that technology was implemented, there have been over 700 correctly flagged pathologies, and the AI does this within 2 to 3 minutes of the scan happening, which is an incredible rate of turnaround. And because it's so quick, it's identified 500 intracranial hemorrhages and 200 pulmonary emboli. And the obvious benefit here is that, it cuts time to figure out if something's seriously wrong and then to implement life-saving treatment or emergency measures. And they found that the overall accuracy of this software, and this is in real clinical practice, is above 90%. And this has really helped streamline the workflows. And again, the idea here is that it augments rather than replaces the hospital radiologist's work. One thing I found interesting about this is this software is always on and just sort of running in the background when scans are taken. And this has gone so well that Matter Misericordia have said they want to trial more specialised AI. In particular, the next one they're looking at implementing, which is going to be this year actually, is one that can analyse bone and chest X-ray images in the emergency department. Yeah, I just think that's a fascinating little case study there.
Yeah, I think it's so cool hearing about these technologies actually being used in hospitals and what they think. And I think it's interesting that all three of the cases we've talked about so far, they're all very similar. They're all for flagging, working with radiologists rather than instead of them. And I think that is, I think some of these ideas always find, sorry to be mathematical, a local minimum or a global minimum of like, this is the best design for this product. And I think maybe human in the loop triaging seems like that could be it.
I think it's interesting as well that like these are things that have been going on in hospitals, because you say AI in hospitals and my brain certainly leaps to, yes, what will be done? Like what might it be able to do? No, it's there and it's working.
It's here already. and now that I've said, isn't it nice that all these things are the same? We're going to talk about something different. So more operationally, what about improving the waiting times for appointments and the waiting times for hospital beds? Hospitals will be run much more efficiently, I think, if you could predict how long people will stay in hospital, when a bed will be made available, and how likely someone will be admitted into the hospital when they show up to A&E. Zella King and colleagues from University College London developed a model to predict just this from real-time data coming in about individuals showing up at A&E, like what visits they had to the hospitals before, their pain levels, their medical readings, and much more that is available from the NHS treasure trove of data, also known as electronic health records. So someone could come to A&E and they would be put into the system, and then the system would say, you should get a bed ready for this person. I think this person is going to need to stay. And also you can forecast it. You can look at trends and say, I think in a couple days, couple weeks, this is how busy it's going to be.
Yeah, no, that's really interesting. Yeah, next Saturday at 9 p.m, get ready.
Yeah. Everyone's going to be coming in. There's a big rugby game or something.
Yeah.
Which I don't know if it looks at the news and the sports listings, probably not. And looking outside of the UK, Langley and colleagues from universities in the state of Virginia in the USA looked at hospitals in developing countries. So I didn't know this, but for many hospitals in emerging economies, the outpatient departments have no appointment systems. And it is a complete first-come, first-serve approach. So this leads to huge queues and potentially people not being able to wait in those queues, not being seen by doctors. So these researchers looked to use AI to help to identify bottlenecks in the system and congestion. I think crucially they weren't trying to implement an appointment system, because I think you can't...
That would be a lot of structural upheaval, wouldn't it, for the system?
You can't shake it up too much and say, make an appointment with the AI in these, fairly rural places. So I think what they wanted to do was just make the current system as well functioning as it can be. And so they looked at a hospital in a city on the coast of China, which I would not have expected to have no appointments in the outpatient departments, but hey. And they studied it over a time period, and AI was able to find problems in the system and rectify them, maybe like redirecting people to some departments, not other departments, and where more resources could be directed to help the flow of patients.
In a similar vein, AI can also be used by scheduling, and by that I mean it can help healthcare practitioners track things like bed and room availability, analyse and determine when a hospital is at its busiest, and then do things like rearrange shifts, depending on the amount of practitioners you need on site at that time. I will say, when I read this, I immediately thought, the human element here could really mess this up. So say that you're a nurse and the AI suddenly says you're scheduled on a day because it's noticed the admissions are ticking up. What happens if you're a single mother who's got got 2 kids and no childminder booked? You can't just magically make yourself available and come in. Just a thought that occurred to me when I read that. I thought, in theory that sounds fantastic. In practice, maybe.
Also, on the other hand, though, I'm not 100% sure how the scheduling systems work currently in hospitals, but I would imagine that maybe it also would not be that kind to single mothers with 2 children and no childminder booked. From complaints down the pub with my doctor friends. I think this may not be better, but it may not be worse.
Fair enough.
No shade to the NHS.
So yeah, so another sort of like more admin-y side of things is that AI can transcribe things like doctor's notes. When we were talking about this the other day, I said I was concerned that like what if a doctor had like a thick accent and the AI couldn't really handle that. And you told me that it's already voice-to-text recognition is already used across the NHS, and it seems to cope, or at least.
Well, so I didn't know this until I was learning about how hospitals work in my kind of master's courses. But yeah, it turns out I don't want to say it's all transcribed, but a lot of the notes that we see from doctors, they're talking into their computer and it's writing them out for them. And I learned this specifically in the context of natural language processing. So this is your classic ChatGPT, things that AIs that read text and come up with some sort of prediction based on that. And it's really hard to do this kind of NLP, natural language processing, on notes written by doctors, that are transcribed by doctors, because, as you said, different accents. Doctors have all their own acronyms for things, and they're not always consistent. They speak very quickly, sometimes in a loud place, so it will pick up on stuff. So if there is an AI that can help with this, I think that's already that's just great.
Yeah,
because it's already a problem. Like it's not like we're going from writing down notes to speaking notes. We're going from speaking notes poorly to speaking notes better.
Hopefully more legible.
Exactly.
Yeah, in this vein, I saw another example of some AI tech that listens to conversations between doctors and patients and just quickly converts that to text, again using natural language processing. Again, I've got to say, I'm sure it's fine, but I have another sort of like gripe about like, consent issues. Do you want everything that's said in like a confidential doctor's appointment to be transcribed and stored and then potentially used as like training material? I assume in that situation, unlike in the emergency phone call situation where you can't get consent, I mean, potentially for this you can, because the doctor can say, is it okay if the algorithm listens in? And you hopefully are able to say yes or no, depending on how you feel. So into, I mean, this is more admin, but it's interesting. So this is basically AI can also help doctors and researchers find potential eligible candidates for clinical trials, basically by quickly analysing their records on the hospital databases and seeing if they would be eligible and then inviting those who might be. And I had a little niggle thinking like, is this a little bit exploitative? But then, Florence, you had a very good point the other day. Do you want to expand on that a little?
Absolutely. Yeah, I think this is brilliant. If before I would have started in any sort of medical field, I would have thought the exact same thing as you. That's weird. So an AI is going to look through a database and see, I think this person would be good for this trial. Like, it feels almost like money making. Like, let's pick the people from the pot. But since working in the field of motor neuron disease and meeting people who are living with motor neuron disease and people affected by motor neuron disease, people want to be in trials. People really want to be in clinical trials, and it's really inconsistent how much people hear about trials. So one doctor, you might have an appointment with the doctor, and the doctor forgets to mention, there's this trial happening, I think you might be eligible. And if the doctor does not say that, the patient will have no idea. Because why would they, unless they seek it out themselves, which a lot of people want to do but may not have the resources to, or just the time, they might not ever be found out to be eligible for a trial, which hurts them because they want to be in a trial because they want to get better, they want to help people with the same disease as them. And also it hurts the trial because there's less people in it, less power, less likely to find a positive, statistically significant result saying, yes, let's take this forward for another trial. So personally, I think even if the AI flags people as being eligible for trial, but actually they're not, that could give them false hope, which is not nice. But I think it's just brilliant that clinical trials could be more successful and patients could have more satisfaction in their disease journey.
Yeah, no, and that is like a really fascinating perspective and one that I hadn't considered myself.
I want to say that it's different for different diseases. I'm speaking purely from the people that I have met who are very plugged into the research field who are affected by motor neuron disease, but I can't speak for every disease where there are clinical trials taking place.
Yeah, no, fair enough. So there are also things like virtual nursing systems, and these can be available 24/7. They can answer your questions, monitor patients, and also provide communication links between patients and doctors to prevent unnecessary healthcare visits or hospital admissions. So they judge that you are sick enough, sort of thing, they can get you in contact with the doctor. I sort of feel like these fall more under the category of like health secretaries than actual nurses. Just, and there's nothing wrong with that at all. I just feel like nurse has specific sort of caring connotations.
Yeah, I agree with that.
Yeah. And Care Angel's virtual nurse assistant does wellness checks using like voice and AI, which sounds like very promising. However, I was thinking like, oh, that might pick up on like someone having a cold for sure. But how would it pick up on, like eczema or like a serious mental health problem? I'm sure there are certain like things that it could analyse and suggest, and I'm not trying to be like overly critical, but just something I was thinking there of like the limitations.
Using the word nurse does feel slightly
it's just slightly
crass.
Out of the bounds of what it does.
Like to me a nurse isn't just someone who just like checks up on people. I don't know. It feels slightly I don't even know what the word is, to be honest. It feels off. It feels off.
Yeah, and speaking of things feeling perhaps a little bit off, I'm going to sort of segue here into my discussion of ethics, consent issues.
Go off.
Yeah, well, so where I wanted to start is just basically like the human factor. So, given what we've discussed so far, AI is certainly an impressive tool that stands to greatly improve areas of healthcare provision. However, healthcare and like sickness and recovery and all these sorts of things are kind of sensitive topics. And there's definitely something comforting and important about having human like doctors and nurses to care for you or your loved ones. Like I would ask, like, would you personally trust your care or the care of a loved one to an AI, even one specially trained in medicine and healthcare? And would you trust the AI to, get it right away? These are just sort of questions to consider, because I imagine that while some people would be very happy for this sort of thing, a lot of people might have like quite big reservations and maybe not want this. Of course, the way I'm saying this, that makes it sound like I'm expecting the AI should take over every level of healthcare, and obviously, as we've been discussing, it's more a supplementary tool. But I think you can still have those reservations, and that's valid. When it comes to like AI and ethics, I always think about the film I, Robot with Will Smith. And
the academic film.
The academic film, and it's very up to date, coming from 2004.
Oh yeah.
But in that film, his character basically had beef with the robots because when he was in a car crash, a robot decided to save him and not a little girl because the little girl was less statistically likely to survive. And he was always going on about how like a human would have tried to save the little girl and all of this. Basically, I'm not trying to suggest that anything like that is going to happen in regard to AI in hospitals. But I do want to, briefly consider some of the issues around the humanness of healthcare and also some sort of ethical considerations that I just think are important.
Especially for those big ethical questions, like the trolley problem. That sort of stuff, like, if that does come up in these sorts of issues, like, who would you save? To be honest, I don't actually see where that could come up in the hospital setting.
No, we haven't got to the point where we're asking the AI to be like, and who do we give the cancer treatment
well,
to?
Exactly. Not quite that dire yet.
Yeah.
But thank you, Will Smith, for putting it all on our minds. Or was it a book before, actually?
It's Isaac Asimov.
I've not seen the film. I've heard of it, and I did not know that was the plot, and now I don't want to watch it.
It's fine as a standalone. I, Robot is like a series of short... Why am I talking about this? Moving on. I like my sci-fi, what can I say?
Fair enough.
Anyhow. Yeah, so like some considerations about AI in hospitals. Is the AI going to work? Will it reliably do what it's supposed to do? Will it make errors? Presumably, yes. Will it make less errors than a human doctor doing the same task? Will it, as we mentioned before, sort of make an error that's so random because the AI like hallucinated is sort of the term people use? Will it sort of make an error and then mistakenly veer off and build upon that error? We don't 100% know the answers to these questions, and AI can be unpredictable.
And this is why I think it's so valuable when papers around AI in medicine include results on how it compares to just a doctor or just a healthcare practitioner. That is really hard to set up, like admin-wise, logistically, because doctors are busy. like we said, radiologists are very busy. They don't want to have to go through loads of scans that are just like, pretend this is just for fun. So it's tricky to get that done. But I think it's super interesting when you can see performance of AI with doctor, performance of doctor. And I think that's much more convincing than, look, it does it to 91% accuracy. Why isn't that great? And it's like, well, yeah. But
humans can be accurate too.
Yeah, well, exactly.
The comparison definitely important. And speaking of like medical personnel, would AI obviate the need for humans like doctors and nurses? I think the answer there is very much no. But like the idea is that AI tools are there to support medical staff, not replace them entirely, because realistically, how could they do so? But will the integration of the AI remove more of the human element, which I think is quite possible? You know, there's even like, you don't talk to the receptionist anymore to sign in, you punch your name into a touchscreen. I can see similar things happening in various areas.
I already get my I already get my blood pressure taken by a machine.
And so there's no human sort of intervention there. You do it and you take a ticket.
In the reception of my doctors, there's some contraption you just need to trust to put your arm into and for it to squeeze it. It's actually quite terrifying. I thought I was going to chop my arm off, but
well, there you go. There's like an aspect of where integration of these technologies removes more of the human element, and this sort of takes away from like the art of medicine, which is already like lacking hugely in our system now, because our system is scientized, which just means that it focuses more on the hard science of like tests and imaging, as opposed to the art side of medicine, which is like caring for a person and allowing them to speak their fears and their worries and trying to calm them down and all of that sort of things, which might sound a little bit wishy-washy, but it genuinely has a huge benefit to patients to know that they are listened to and that they're being taken seriously. These things have like a measurable impact on their well-being. People are more likely to recover and to recover quickly when they are being seen by a practitioner who gives them the time of day and looks after them in that sort of way. And I do worry that if we strip away that side of things too much, that it will actually have a negative effect on people. We don't want to get too cold and too clinical, because we're human beings and we actually do need occasionally, people to act like they care about us, potentially, that kind of thing. It is important.
On the other side, could putting AI in hospitals give practitioners more time to focus on that human side?
That's a really good point. Yeah, I mean, if the AI frees up time doing admin, then maybe you might have more time to have one-on-ones with patients and care for them and make sure they feel like looked after.
Yeah. Bit of a utopian look on it, because on the contrast I could see we've got more time to see more patients and do more things and maybe sack off some nurses, because now we can do more with less people, but you never know what actually is going to happen.
Exactly. I mean, loads of this is up in the air, and it's helpful, if I'm being pessimistic over here, it's helpful for you to come in with the slightly more optimistic look at things. Going back to the slightly more pessimistic, will the implementation of AI make our health professionals de-skilled? Will they stop having certain knowledge or stop knowing certain techniques, for example, if the AI takes over? Like if we look at our radiologists, say, for example, the AI takes over the bulk of the work, will the radiologist become less adept at evaluating these scans and things like that? Maybe, maybe not. I mean, as you say, we desperately do need radiologists, and the AI can't be left to do it all by itself at the moment. But say something like that did happen and health professionals become de-skilled in a certain area, if the AI system then went offline or, it stopped being updated or what have you, would they be able to cope? And the flip side of this is that with AI systems being integrated into hospitals, potentially healthcare professionals are going to have to put in some considerable time and effort learning how to use the system or to work around it.
Absolutely.
So that's like they've already run off their feet and there is no time, and their shifts are already 1,000 hours long. And
hey,
things like
do you want to do some more training?
Yeah, that's
yes,
something that I is mildly concerning. There's also like consent issues will patients get a choice? Like, will they be informed or even ask for consent for AI to be used as part of their care? I think it's fairly benign in a lot of cases, in a lot of like situations. But at the same time, I feel like people should have the right certainly to know and potentially to opt out of something like this if they wanted to. You should have rights, data rights and rights to privacy and all this sort of thing, that it kind of feels like these technologies just sort of skip over. Like, yeah, in some of the examples we gave above, it was kind of clear that people were not being consulted. So yeah, it you know, it's for the quote unquote greater good, but I find parts of that slightly unsettling.
It's very hot fuzz. The greater good.
The greater good.
The greater good.
And then yeah, like a final point is potentially AI could replicate, sustain, or even worsen existing inequalities and disparities in healthcare. Like the healthcare system as it stands, it upholds societal hierarchies. For example, like misogyny and racism. There's things like, there are studies that have been done that found like medical professionals and medical trainees even today will evaluate a black person's pain as lower compared to a white person, and therefore be less likely to give them adequate or any pain medication, things like that. Also, very much in this country, there is a huge disparity in, how to put this, in maternal health and maternal deaths between like white and black and brown women. These sort of things are unfortunately built into the system, and this equates to poor healthcare provision for like non-dominant groups. And this also leads to like worse health in these groups. If the data that the AI is learning from is coming from this existing system, will it repeat or worsen existing issues? And also, like, algorithms themselves are not objective or unbiased. They are programmed by biased and prejudiced humans, and these sorts of things can bleed into how the tech works. So, I don't know, again, I don't want to fearmonger, but I think it's worth considering.
And I would say there's some very interesting work going on around how to make AI less biased, even when using data that is inherently biased, because humans have collected it. It is about humans. There's some very interesting work going on about that, about misogyny, racism, but also about people who are not in the healthcare system. So refugees who come to the UK, for example, probably won't have gone to a GP, and so their problems will not be in the data. So some interesting work going on around that. I would recommend having a look.
Yeah, no, really interesting. So, to combat these sort of issues, there is the idea of establishing ethical guidelines before implementing AI. However, it is, for some situations, it is kind of too late, like the AIs have been implemented. And some people would argue that ethics in AI is sort of a useless or meaningless endeavour. And what I mean by that, so there's this brilliant article called The Uselessness of AI Ethics by Munn. This came out in 2023. And he basically argues that principles of ethics in AI are kind of useless, and he splits it down into they are meaningless, they are isolated, and they are toothless. So they are meaningless in that values that are battered around like fairness and privacy, when you try to actually actively define what they mean in terms of AI, they are very sort of vague. And then trying to implement, okay, we're going to make this fair, we're going to make the AI fair. What that actually means can mean different things to like loads of different people. And he said it's sort of this like ambiguity, it just sort of comes down to ethical box ticking. So a company can say, oh yes, well our principles are that it's fair and that things are kept private and all of this, without actually meaningfully implementing anything. Ethics in AI is also really isolated. Like the tech industry that produces this AI lacks ethics. There's a huge sort of amount of toxic misogyny and racism in this industry. So, and ethics are not really integrated into teaching computer science programs and therefore into programming AI. So it's like ethics is this odd little bubble outside of what AI actually is and can be, and it's not meaningfully integrated. And finally, he says, ethics in AI are toothless in that there aren't really sanctions for, there are no consequences for an AI that does something unethical at the moment. So, there are no enforcement mechanisms, and often people's desire for money far outweighs their desire for making the AI program ethical. That all sounds a little pessimistic, but I just wanted to lob that out there because I think it's really interesting.
It's good to know.
And it is something to consider when we talk about AI in healthcare.
So we've talked about kind of research and ethics, but what is actually happening now, like right now? So one question that's asked quite a lot is, are smart hospitals the future of healthcare? And I'd actually not heard of smart hospitals or the concept of smart hospitals, and probably because there's actually no properly agreed definition that we've found on what they are. But I think we both kind of agreed that the more AI is integrated to a hospital, probably the more it becomes a smart hospital. And a 2022 article from Insider Intelligence suggests that the experts say, those experts, they say a smart hospital will be one that not only uses AI and machine learning to learn from data, from sensors and processed in some sort of data center, but also to trigger action. So making sure that something is acted on because of this learning. So the idea is that a smart hospital will build automation around it to implement actions. So, I don't know, an AI sees someone in a bed, has a cough, and then the hospital does something to help that patient instead of alerting someone and then that person has to go do it. That's my interpretation of what that means. And kind of looking at the UK specifically, as we've been doing a little bit, because we are from the UK, unfortunately. So there's a couple of arms of our National Health Service called the NHS, dedicated to looking at AI and tech being used within hospitals, and one of them is called NHSX, which was a department promoting technology within the NHS for stuff like streamlining processes, making tech more available, app development specifically for the NHS, digital training for staff, stuff like that. And in 2022, the NHSX died and was very sad, and merged with the Transformation Directorate at NHS England to become NHS England's Transformation Directorate.
Really rolls off the tongue.
Yeah, my humble opinion,
it?
a much less catchy title. NHSX was such a cool name for a department, but never mind. A similar department also in the NHS is the NHS AI Lab, which more specifically, guessing from the name, looks at AI for medical purposes, as well as very important areas that we've talked about of ethics and regulation, which you would hope that the NHS was looking into, so I'm glad that they are. People in the UK, you would definitely recognise NHSX's work, as they were the ones that produced the COVID Pass app, which, in short, it was an app that was used during the pandemic, where you would check into a place using this app, say like a pub or a restaurant, and then if someone got COVID who had also checked in there, the app would say, "Whoa, you might have COVID." And
exactly like that.
Yeah, it did that exact soundbite. It emanated from your phone. Whoa. Yeah, and I mean, apart from that, what's going on now, it's working on making imaging more accessible for researchers to use to train their AI tools, which is a hugely valuable initiative, because the AI is only good as the data you're putting in, and if you've only got 100 scans, it's not going to be very smart. It's like a doctor who's only seen 100 scans. So yes. I think that's a really valuable initiative that they're working on. They do some cool stuff.
Nice. So we're going to discuss a couple of limitations here. Obviously, we've sort of been doing
that. Yeah, I feel like we've been doing that throughout the episode.
So one thing we wanted to talk about was sustainability of this tech, basically. So as a cautionary tale, I was going to bring up the AI winter. I know. So an AI winter is basically a period of decreased funding and interest in AI research, which does sort of follow a cyclical pattern. This comes in waves, and things can be revived by renewed interest in the subject. Between the 1970s and the 2000s, this is considered like the AI winter. Specifically, two bouts between 1974 and 1980, and then 1987 and 2000, with other sort of like smaller episodes in there too. And yeah, this term comes from the 1984 meeting of the American Association of Artificial Intelligence, when AI researchers Roger Schank and Marvin Minsky warned that basically the enthusiasm for AI had become so heated that it would inevitably lead to like a big letdown and disappointment, which would then usher in a nuclear winter of pessimism regarding AI and a lack of funding, etc. So, say at the moment we're in like
AI summer.
Yep. In that, loads of like research and funding and everything is going into AI and getting AI implemented into our healthcare systems. What happens if, the bubble bursts and there suddenly isn't any more money for this, and systems can't then keep being updated, and you end up with legacy tech, basically, that is, the hospital's absolutely riddled with it and it no longer works in the way that it's supposed to. it's a possibility. It's definitely something to think about because, I mean, particularly in the NHS, it's not like... I was going to sound like a bit of a diss. I was going to say, like, not... Their technology isn't always like the most up to date and the most cutting edge.
Fair. That is a good point. It's not exactly false.
Yeah. So what happens if these sort of systems fall into disrepair? It's something to consider for sure.
Another limitation that I touched on earlier regards like generalizability, and I talked about it in terms of one hospital has a different population to another hospital. But what about kind of in a bit of a less interesting way, but geography in deploying AI systems? Like, one system might not be set up for a hospital in England, but might be set up for a hospital in Scotland. And I think that is tricky if you're someone trying to implement AI. To fit it into all the different hospitals is an absolute nightmare. And specifically with England and Scotland, the NHS, even though it's both, the NHS is both in the UK, they work very differently from one another, and it is much easier to implement AI systems within NHS Scotland for a number of reasons, but one of those reasons is that NHS Scotland has a Scotland-wide imaging platform for researchers to access images and develop tools on them. So it'd be a lot easier to do, say, the AI triaging of brain MRI within Scotland, and much harder in England because all the different NHS trusts in England all do different things, which is super handy.
Yeah, and I'd never heard of this or considered this, so this is some fascinating context to some of the logistical issues here.
Yeah, it's an absolute nightmare. Another huge problem in AI being used in hospitals is the need for explainability, and we actually haven't touched on this yet, but it is a really, really crucial area for AI medicine. And by explainability, and it could also be called interpretability just as a caveat, but it's basically, can the AI tell you why it's saying what it's saying? What about this MRI is making you think it needs a second look? Explainable AI is a big field, lots of methods for trying to access an AI's reasoning, and that can be really difficult because of very complex methods involved. It can be hard to be like, but is it on the left side of the image? And a lot of people think it's absolutely crucial to have doctors and healthcare providers trust what the AI is telling them instead of the AI just being like, just trust me, bro, like, it's fine. And explainable AI has even been used to debunk some AI tools that have already been published in research papers that claim to be able to detect COVID from X-ray images. But after scrutinization with explainability methods, it turned out that AI was actually looking nowhere near the lungs in these X-ray images. It was looking at other features of the image that gave the AI clues to what was happening. One example was an icon on the image indicating whether the patient was standing up or lying down during the X-ray. So if the patient was lying down, it probably meant they were too weak to stand up, which probably means they had COVID. So it was these sorts of things where if you had not done an explainability method on that AI, you would not have seen that, and you would have been like, brilliant, 95% accuracy, good. Let's go, let's deploy it, and then it would just completely fail. And kind of finally, moving on from the last episode on wearable tech where we discussed data security and privacy at length, it's probably no surprise that we're talking about that again. So with any AI system, it needs data to learn, and the data has to move about places, putting it at risk of leaking and hacking, etc. One potential solution to this is something called federated learning, which I'll touch on briefly, and it's a technique for different sources of data to contribute to the training of an AI model without the data having to move anywhere. So in the example of hospital data training AI, the data in the hospital would not have to leave the hospital for the AI to still be created. And it's much better than the alternative of sending personal medical data, even if it's been anonymised across the internet, in a zip file on an email.
Yes.
Which is sadly
which anyone could reach out and grab.
It's got a password, but you know.
So we're coming to the end of our episode here. One little thing I found that I thought was really interesting regarding the potential future use of AI in healthcare. This is from a paper by Bohr and Memezeda in 2020, and they said, it is believed that within the next decade, a large part of the global population will be offered full genome sequencing either at birth or in adult life. Such genome sequencing is estimated to take up, good lord, 100,000 and 150 gigabytes of data, and will allow a great tool for precision medicine. Interfacing the genomic and phenotype information is still ongoing, and the current clinical system would need a redesign to be able to use such genomics data and the benefits hereof.
But hereof.
quite quick marks around all of that.
Yeah.
But I think that's really interesting, like the idea that in the future we might just be able to go like, bloop, there's your whole like genome, and based on that, he's like potentially personalised medicines, predictions, prognosis, like all of this sort of thing.
It's mad.
Yeah, we shall see. If that comes to pass.
Watch out for series 102 when we'll be talking about genome-wide analysis.
So yeah, I think that'll do it on this episode on our discussion of AI in hospitals. What are some of our key takeaways here?
So I would say a key takeaway is be sceptical. It does pay to be sceptical and think kind of what is the real implication of these systems, but also don't be too sceptical. You know, these things are all works in progress. If they're implemented in hospitals, then they probably have gone through quite a lot of regulation and ethics with all the boards and the people who are in charge of the hospitals. So I wouldn't be too scared about that. But for research papers that haven't been put into hospitals yet, you know, take a look around, see what you think. If you think something doesn't look so good, keep note of it, critically think.
Absolutely. I also think, like I said, I was being a bit of a Luddite in this episode, but I mean, it's not going to replace human medical professionals completely. It's going to be assisting them, and you probably won't even notice it. And I mean, it is already here, and it is likely here to stay, unless we do end up with a catastrophic AI winter, and then goodness knows what's going to happen.
I hope that isn't the case
fingers
for my career prospects.
Yes.
Yes.
So yeah, thank you guys for listening, and next time we're going to be talking about AI in surgery, which is... Oh, you're going to enjoy it. I'm going to enjoy it.
You're going to love it. All right, we hope you enjoyed it, and we'll see you next time.
Thank you very much for listening to this episode of Day-to-Day Health. If you've got any questions or comments, please DM us on our Instagram @DayTodayHealth or email us at daytodayhealth@gmail.com. Also, this podcast was created as part of the Turing-Roche Community Scholar Scheme, but all opinions expressed aren't those of the Alan Turing Institute or Roche. The show notes, transcripts and references to the research we talk about can be found at daytodayhealth.github.io. That does it for us, and we'll catch you next time.